Thank you very much, and welcome to everyone. My name is Simon Higgins. I'm with Canada Health Infoway, and I'm going to be moderating the discussion today. We have got a great set of data and analysis today on the growth of the iEHR in Canada, user adoption landscape, and benefits. And the findings today will be presented by Sukirtha Tharmalingam and Bobby Georgiou. Before I turn the floor over to Sukirtha and Bobby to walk through their findings, just a few housekeeping notes. So this will be recorded for future use. I just wanted to follow up on what Tamara had said about the question function. So we'll just put up a picture of the screen. So this is the question asking placed on the screen. All the lines are muted, but we really would like to get lots of questions today. So please, as the webinar is going, go ahead and submit your questions so that we can have them all queued up at the end when we start the Q&A piece. And then finally, just a disclaimer that these are our views and our analysis, and they're for your information purposes. And with that, I will turn it over and welcome Bobby Georgiou to start off the presentation.
Great. Thank you very much, Simon. Hello, everyone. To start off, I just wanted to highlight the objectives of this presentation. The first part, which I'll be speaking to, is to explain the methodology behind our adoption measures, to show you some of our latest adoption trends and results, and to provide a context for those measures within the national landscape. I will then pass it over to my colleague Sukirtha, who will get into users' experience with the iEHR through various studies that we've conducted across the country. And she'll speak to the concept of a maturity model and how benefits can be demonstrated over time. So for those of you who may not be familiar with Canada Health Infoway, we were established in 2001. We're an independent, not-for-profit corporation, and we're equally accountable to the 14 federal and provincial territorial governments. And our mission is to help accelerate the development, adoption, and effective use of digital health across the country. Since our inception, we've received $2.15 billion in capitalization funds from the federal government, and we've invested that money in partnership with our partners in the provinces and territories in the buckets that are outlined below on this slide. And you can see that electronic health records and the EHR, they form a large part of our historical investment. So to define the iEHR, the Interoperable Electronic Health Record, our definition is that it is a secure, integrated view of a person's medical record from all systems in the network, and it provides a comprehensive view of a patient's medical history. It's similar in concept to a health information exchange, the term that is used more frequently in the U.S., but it is distinct from an EMR, which tends to be a primary patient record that you would typically find, let's say, in a physician's office. It is also distinct from a hospital information system. Those would typically be points of care that would also provide access to the EHR if integrated. And I will give some more descriptions of how these systems fit later on. As a matter of fact, on this slide, we could spend an entire hour just speaking about this slide. I certainly won't do that, but it gives you a sense of what the EHR is. Essentially, you've got across the bottom a number of point-of-care systems that access data stored in provincial territorial repositories, which you can find across the top. So you've got holdings of drug information data, lab system data, digital images, all which can be accessed through either a viewer or an integrated connection through an EMR or hospital information system. So now the focus of this presentation is on the adoption of the iEHR. And we've reported on adoption and on benefits in different ways. And I will walk you through some of the different measures, different types of reports that we've compiled in order to give you a deeper sense of the progress on the iEHR front. The first piece deals with availability. And in the first few years of building the EHR, that was a primary measure because we wanted to first make sure that these systems are up and running and operational and that our end users, clinicians, other health system professionals had access to these systems. So on the next slide, there's just an overview, excuse me, of the current provincial and territorial picture, when each EHR went live in those provinces, in what settings are they currently able to access iEHRs, and what type of clinical domains are accessible. So for example, in some jurisdictions you can access labs and DI reports, and others you can access drug information, allergies, immunization data. So this provides a look at what is accessed. On the next slide, it's more of a wrap of an aggregate view. So across the country, what type of information is available to authorized users? And you can see that our registries are up and running, so client and provider demographics, that's available across the board. Digital images, clinical reports or immunizations, those are all available. Telehealth, video conferencing is available in almost all hospitals across the country. Lab test results, 95% of provinces and territories have access to provincial lab test results. And 69% of provinces and territories have access to drug information systems. So that's the availability picture. What this doesn't tell us is how often these systems are actually being used and who is using these systems. So we move to the next section of reporting, and that is the use part. And in order to measure use, we look at data collected from provincial and territorial systems, so access logs and so on, that give us a sense of how many people, how many distinct users of the system, how frequently they're accessing it. We also supplement that information with survey data. So we run a number of surveys, either initiated by us or in partnership with external partners like the Commonwealth Fund, previously with the National Physician Survey, the CPHA, and that gives us an even broader and better sense of who is using these systems, who needs to use these systems, what types of functionality are desired by clinicians in order to paint a better picture of current use and the overall landscape, so who would ideally be using these systems. So we take that data, we use it to generate trends in adoption, which I'll share with you later. We also use it to derive cumulative benefits calculations, and I'll give you some examples there. And we publish that information externally in our annual reports, pan-Canadian studies, which I'll touch upon later. We provide some international comparisons. We also use it internally to drive our strategies and to track against project deliverables. So in developing some of these measures, we used a number of core principles to make sure that what we're putting out there, for one, is comprehensive, that it captures different types of access to the EHR through different systems that may be deployed throughout the country, that the metrics are simple, easy to understand and communicate, that they're reliable year to year so that we can develop meaningful trends. We want the data to be comparable, so one jurisdiction to another, they may have different types of systems deployed, but we wanted to use consistent metrics so that we can aggregate the data reliably. Lastly, we wanted coherent information so that the numbers reflect what is actually happening on the ground. If we have a new system going up live, a lot of people are using it, that we see that growth reflected in our annual trends. And we also developed a metric, call it the active user, to track frequency of use to the system, and to ensure that the numbers we report are reflective of people who actually use these systems regularly as part of their work activities. So we defined active users as access to 2 or more integrated data assets. So we wanted to make sure that clinicians, other health system professionals are accessing 2 or more systems like drug information systems, lab systems, DI, that they're accessing the system at least once a month, to touch off on that frequency, that this is part of a relevant part of their work activity. And we deemed that those users that are using integrated systems, so an EMR that has a data feed to these provincial repositories, we deem those to be active users, since they're likely going to be accessing this data on a regular basis. It will be fed into their systems. This concept is used in other industries. Social media, for example, is quite big on this active use concept. You frequently hear when companies are being evaluated, when Twitter had its IPO, Facebook, active use was a core metric, because you could have billions of people registered, but it's more valuable who are those people that are using this on a regular basis. So we've used the same approach for our measurements. So on this slide, we're showing a 10-year trend of where we are with active use of the electronic health record across the country. And the most recent data as of January of this year, we had close to 140,000 active users. That actually represents more than 50% growth since the previous year. And as you can see from the shape of this curve, the past 2 or 3 years has really seen an acceleration in the active use of these systems, partly because more systems, more provinces and territories have come on board and have gone live with EHRs, but also because we've reached a kind of critical mass of users. The more clinicians are actively using the system, the more valuable it becomes, and we can see that in this accelerating trend. On the next slide, we're looking at the same numbers, but I broke it down between access through a viewer and integrated access, so point-of-care systems that are directly tapped into the EHR. And we can see that over the past couple of years, a bigger proportion has been integrated use, and we're hoping to see that continue to grow, since an integrated EHR is likely to be more in line with clinician workflow and usability. So it's encouraging to see that trend develop. I mentioned also that in addition to system-generated data and user logs, we also survey clinicians on their access to the EHR. And on our most recent round of surveys, we observed that 53% of pharmacists have indicated that they can access an electronic list of medications through a provincial drug information system. During our last nursing survey, 44% of nurses indicated that they have access to provincial or territorial patient information systems that could be drug, lab, or DI. And also 37% of physicians that we've surveyed indicated that they have access to provincial or territorial systems as well. So by triangulating this data, both on the clinician front and the user logs, we've developed a user adoption landscape to give us a richer understanding of the use of these systems across the country. So you see the yellow triangle at the bottom, that's the 139,000 active users that we've covered. If we look at the clinician survey data that looked at, can you access any one of the clinical domains available, we have an estimate of about close to 260,000 users of one or more domains. And if we look at the entire landscape using data from CIHI, from StatsCan, of the total number of clinicians across the country, the number of other health system professionals that we might expect would use the system, we're predicting that about there are about 500,000 potential users of the EHR. So in some sense, we're more than halfway towards that line. We still have a significant way to go towards giving clinicians and other health system professionals access to the EHR, but it's definitely something that has accelerated significantly in the past couple of years. And then I mentioned the last type of reporting on adoption and benefits. This is the benefits piece. Just wanted to touch a little bit on how our adoption metrics drive our benefits estimates. So in our approach to putting a value on the EHR, we first looked at evidence out there to inform our value proposition. We developed indicators and tools. There's the methodology behind tracking adoption that I described. We developed survey tools to get clinician opinions. We monitored those. We looked at project evaluations, which Sakurtha is going to get into more detail, compiled surveys, further research, and lastly, pan-Canadian studies. And pan-Canadian studies, we've completed 5, 6 if you count remote patient monitoring. But essentially, we started off with diagnostic imaging in 2008, followed that up with drug information systems, telehealth, and then EMRs in both primary care and ambulatory. And what these studies did is present a very detailed landscape of the use of these systems across the country and also derive some cumulative benefits in terms of productivity, in terms of cost avoidance to the health system, all of which we aggregate in an estimate of net benefits or aggregate benefits over time. We started tracking this in 2007 and have tracked it every year. And as the use of the iEHR has grown, we have predicted similar growth in the benefits that have been derived. We can say at this point that these investments have resulted in more than $16 billion in aggregate benefits since 2007, and this chart demonstrates each component and what they have contributed to the overall benefits calculation. So in order to wrap up, just wanted to summarize the importance and the value of measuring use. Definitely it allows for multi-year trending and monitoring of the progress of our investments. It enables a target-driven approach for project reimbursement. So this is something that we have built into our project agreements, that not only do we want projects to be completed and systems to be built, but we have significant funds held aside that can only be released when adoption is demonstrated. So that's been a big driver of increasing adoption over time. And lastly, this ensures a critical mass of users as a foundation for continued development and innovation. So we're not done with the iEHR. It really is a platform now that we can build, and we can look at providing access to additional types of information systems. We can look at long-term care, we can look at home care, and we can also look at patient access to electronic health information. All that can be done now that we have this both critical mass of users, but infrastructure built. So in wrap-up, I just provided a link to a paper that Simon and I published earlier this year. It provides more details on our measurement of adoption and the potential impact for continuing to track adoption and demonstrate benefits. And with that in mind, I'm going to pass it to my colleague Sukrita, who will get more into project-level benefits calculations and as well how they tie into the iEHR concept.
Great. Thanks, Bobby. So as Bobby mentioned, I'll discuss some of the benefits that we're starting to see emerging from the iEHRs, and a lot of the findings that I'm sharing are based on another paper we published this summer looking at the value of connected health information, largely based on user perceptions. So evaluating the value of iEHRs is a new and evolving area of digital health research. A number of researchers in Canada have looked at the benefits of individual components, clinical components of the iEHRs. And many of these results, including some of the Infoway-led pan-Canadian studies, look at the value that's generated from sharing specific types of information. So for example, we have evidence on benefits seen from diagnostic imaging information systems or drug information systems. But there's been limited evidence on the impact of iEHRs as an integrated approach to sharing many different types of clinical data. When we look to the states, we're starting to see evidence emerging on the value of health information exchanges, or HIEs, which are very similar to the concept of iEHRs. And particularly in the last few years, we're starting to see a number of review papers looking at synthesizing the impact that HIEs are having in different care settings and on the healthcare system overall. So our approach to understanding the value of iEHRs is also attentive to synthesize the available and existing evidence. We started by looking across the country for evaluations conducted on provincial territorial iEHRs, whether they were led by our investment project evaluations or individual jurisdictions. We looked at evaluations where users had access to at least 2 or more of the core clinical data components like lab, diagnostic imaging, or drug information. At the time we undertook the synthesis, we only looked at evaluation results available by December 2015. And it was also important that the evaluations utilized a system in use survey tool that was built around important dimensions of the National Benefit Evaluation Framework. Many of you are familiar with this framework, which focuses on the relationship between the implementation, adoption, and impacts of digital health solutions. The use of this framework, with some customizations of the survey tool emerging from this among the jurisdictions, gave us a uniform methodology to identify common aspects for analysis. So using this criteria, we identified 6 different PT evaluations where data existed for us to analyze. So when it came to synthesizing the data, we started by pulling all of the questions from the 6 surveys to identify commonalities. If questions were common in at least 2 or more of the surveys, those were retained for analysis. So this resulted in a total of 21 questions that addressed aspects of the framework dimensions such as system, information, or service quality, iEHR use, and user satisfaction, or net quality and productivity benefits. We then classified the responses to these questions as positive, negative, or mixed. This is an approach that's quite useful when you're addressing the challenges of aggregating diverse and nuanced findings from a range of studies. This methodology has been applied in similar synthesis type studies in health information technology, and we have this validated as an appropriate method to use to understand these evaluations by 2 external subject matter experts. So basically, we looked at the responses for each of the 21 questions for each of the 6 PTs where we have the data, and if 50% or more of the respondents reported a satisfactory rating or experience for a question, it was classified a positive outcome. Now, many of the questions in the survey consisted of 5-item Likert type scale response categories, so this typically represented the top 2 response options. And if 50% or more of the survey respondents reported a dissatisfactory rating or experience for a given question, typically representing the bottom 2 response options on a 5-item Likert type scale, they were classified as a negative outcome. And any other combination of responses was classified mixed. So the 6 PT evaluations used in this study were conducted anywhere from 2008 to 2014. Together, the surveys had a total sample of over 2,300 respondents. The largest group of respondents were nurse and nurse practitioners, who made up anywhere from 33 to 51% of the respondents among the evaluations. And physicians also made up anywhere from 12 to 49% of the respondents, depending on the evaluation. Administrative staff and allied health professionals also accounted for a notable share of respondents in some of the provinces and territories. Acute care, emergency departments, and primary care were among respondents' most common practice settings, and all of the 6 evaluation data came from users with access to at least lab test results and diagnostic imaging reports. In some cases, additional information such as medications, clinical reports, and immunization profiles were available. Unfortunately, not all surveys asked respondents about how long they had used their iEHRs, so we weren't able to assess this for all of the evaluations. But in most cases, respondents had used the iEHR for a year or less. So now we can dive into some of the results that we saw. So as I mentioned earlier, we used the BE framework to help us guide the understanding of user experiences. So we focus on the left part of the framework. We have areas that look at the quality of the system, information, and service. The System quality looks at how users viewed the performance, the reliability, and security of the iEHR system. So there we identified a total of 8 outcomes that related to system quality, and of those, 7 were positive, meaning more than half of the respondents gave a positive ranking and 1 was mixed. Information quality was perhaps the best studied dimension from this synthesis because all of the 6 evaluations had questions that addressed this domain, had 1 or more questions that addressed this domain. So when we're talking about information quality, users were asked questions that assess the overall quality of information they were accessing, such as lab results or DI or any other clinical information. They were asked about their ability to access information they might have previously accessed through other means, the layout, format of the information, the accuracy of the information, and the availability of information, whether it was available quickly and when they needed it. And we saw an overwhelmingly positive outcomes for this dimension. In assessing service quality, there were a number of evaluations that looked at training and support that was received by users. There weren't as many outcomes studied related to this area, but among the 4 that looked at this aspect, 3 had positive ratings and 1 had mixed. So moving to the center of the BE framework that looks at use and user satisfaction, which was also examined in all 6 of the evaluations, resulting in a total of 15 outcomes that we could look at that address things like overall satisfaction, ease of use, and whether the use was integrated into their workflow and made it easy, made their jobs easier. You can see majority of the respondents had reported positive outcomes. Now we move to the net benefit aspects of the BE framework, which is our ultimate goal to understand how electronic sharing of information can improve quality of care and productivity gains across the healthcare system. So we'll start with the quality of care, which is 15 positive outcomes out of a total of 18. Quality of care net benefits addressed questions such as simply asking users if they felt the iEHRs was improving the quality of their ability to provide quality of care. They were also asked if it helped in their clinical decision-making, if it improved sharing of information among providers, and if it had any impact on their ability to coordinate patient care. Users were also asked whether the iEHRs improved their productivity and other efficiency-related impact of iEHRs, such as efficiency in accessing diagnostic imaging or lab information, reducing the need to obtain information manually, reducing the duplicate ordering of lab tests and DI. So again, we had more positive outcomes, but note that we have a greater number of mixed and negative findings in this area. So in summary, what we have here is the first cross-jurisdictional assessment of the value of iEHRs from the perspective of their users. So the 6 the provinces and territories that we looked at in this study make up over 11 million Canadians, serving nearly 1/3 of the Canadian population. What's interesting about this type of synthesis and finding is that it gives us the unique insights from those who use the iEHRs to access shared patient information. And we can draw a couple of conclusions. So using the methodology that we have, information quality was certainly the most studied aspect among the evaluations, with a high ratio of overall positive to mixed, neutral, and negative outcomes. The degree of consistency in the findings across all the dimensions studied is also noteworthy. Overall, users in the 6 provinces and territories included in this analysis tend to view the iEHR as a positive thing. As with most research, there are some challenges to bear in mind when we're interpreting these findings. So while we had the consistency of the benefit evaluation framework and the system and use survey tool, there was definitely customization of the tool to meet the local needs of individual evaluations. And as well, the sample sizes varied among the 6 evaluations and response rates varied. Because keep in mind, these evaluations were conducted as part of project evaluations to understand as systems were implemented. And in addition, what we did in this analysis is gave equal weighting to all studies. And we intentionally did this to account for the variations that we see among the 6 evaluations. Another thing to note is that we span an 8-year period from in this synthesis, and these findings might not necessarily be reflective of the current status of the PT iEHRs, and we know that all of them that we've looked at, the results we've presented in each of those evaluations, they've progressed over time in scope, adoption, and maturity of use. There is also iEHRs across the country where we did not have similar survey data for comparison, so they're not included, and those user views are not reflected in here. It's also important to keep in mind the variations in care settings among the evaluations, the jurisdictional context, and what type of solutions were used, when they were introduced, what domains of information clinicians had access to, and how often they had used it before completing the survey, are all important details to keep in mind when we're looking at these findings. What we were able to do was glean some insights on benefit realization by looking at some of the patterns observed in some of the individual PT evaluations. So we presented the aggregate information in the previous slides, but when we went and looked at some individual evaluations, we see that the maturity of benefits occur over time with concerted efforts. When we reflect back to the BE framework, the aspects of the system and service quality seem to emerge as foundational to realizing benefits. And our study revealed a number of key potential drivers of net benefits from iEHRs. So, for example, in evaluations that had higher ratings for their system and its integration with other systems they were already using, they tend to report higher use satisfaction or higher net benefits in areas of quality and productivity. As well as in evaluations, we noticed that effective change management played a key role in realizing benefits. So in evaluations where users felt there was a coordinated and cohesive approach to the implementation, to the iEHR implementation, with leadership, adequate training and support, and effective integration into workflow, they saw higher user acceptance of the system and net benefits. And particularly, we were able to understand the maturity of these benefits when evaluations had been repeated over time. So we, in a number of evaluations, we've only presented the most updated findings up to 2015 in this analysis, but in certain cases, we were able to go back and look at what had changed over time, and that made us come to these factors as some that drive benefit realization. So for us, this study suggests many directions for future evaluations. What we really have here is the evidence on early benefits relating to information availability. And we're focusing most of our future efforts and current efforts is on understanding some of the medium and longer term benefits from iEHRs that reflect efficiency gains and impact on patient care. We have research currently underway understanding the impact of iEHRs on care delivery in different settings like the primary care environment and the long-term care setting. And we're looking at other research efforts that are going to fill the gap in quantifying some of the specific impacts on care. So we also look forward to developing a pan-Canadian benefit estimate for the iEHRs. And as Bobby mentioned, we anticipate that the sum of the estimates that have been generated on the individual components to date will generate higher benefits than the sum of the components that have been generated to date. And we want to invite those of you that are working on evaluations currently or have evidence available that relate to understanding the value of iEHRs to connect with us and to share your evidence, and so as we continue to advance our research in this area.
Great. So thank you very much, Sukrita, and thank you, Bobby, for those presentations. We've got a good chunk of time for questions, and so I would like to encourage you all to submit your questions now. Please remember, when you submit questions, submit to all panelists so that all of us coordinating the webinar can see them, and I will be passing them on to Bobby and Sukrita over the next few minutes. So first question for you, and this one, Bobby, I'll direct to you. And Sukrita, I wonder if you wouldn't mind going to slide 26, because it relates to the cumulative benefits estimates that Bobby spoke to. So the question is the lab domain is absent from this chart, and why is that? Are there financial benefits related to lab, or why is lab not shown here?
Okay. So there are a couple of reasons for that. One is we have not conducted a pan-Canadian study specifically directed at labs. So these figures only include those benefits that have been calculated and validated through pan-Canadian studies. But I can say that labs were part of both the primary care EMR pan-Canadian study and the ambulatory EMR. So we looked at benefits related to reducing lab duplicates, as well as improved diagnostic test management, so retrieving, archiving, accessing lab results and so on, and the efficiencies related to those activities. So we could say that part of those benefits for both ambulatory and physician office EMRs are directed to labs.
Great. Thank you very much, Bobby. So the next question, I'm going to direct this one to Sukrita, and it relates to slide 37, if you want to go to slide 37. And the question is, looking at the framework, you've spoken to quality benefits and productivity benefits, but not to access benefits. And I was wondering, this question was wondering if you could comment on that.
Sure. So as I mentioned, the framework that we used, this is the framework we used, and the survey tool accompanying this was built on the questions here. But when it came to the questions that we had, access was not something that was addressed in those surveys, and mainly because it involved a lot of patient and provider type interactions. And so with the iEHRs, a lot of our focus on the questions were related to the information availability for providers. Certainly, I think as we move further into our evaluations in iEHRs and as more users gain access, that would be a domain that we would start seeing some results in.
Thank you, Sukrita. So the next question here that I'll direct to Bobby, and it's about the active user definition. And the question is, does access to just demographics count as an active user?
Okay, thank you. So the answer is no. We wanted to restrict it to access to clinical domains. So it would have to be 2 or more of diagnostic imaging, drug, lab. We assume that demographics would have to be part of any functioning EHR. So we did not include that as counting towards an active use definition.
Great. Thanks very much, Bobby. So another question here, which is for both of you, but maybe I'll suggest that Sukrita field this one. So there's reference to a number of surveys of clinicians in the adoption reporting, a lot of surveys that you were reporting on, Sukrita, around the adoption and benefits of the EHRs in different provinces. Is any of this survey data available to the folks on the webinar?
Sure, so great question, and much of our data is available online on our website through our benefit evaluation report. You can see much of the evaluation type data that we have. As well, a lot of the clinician surveys, we also have the National Physician Survey results, the nursing survey results, and pharmacist survey results, all available through our website. And you know, if you're having difficulties finding those results, you can get in touch with us, and we'd certainly be happy to connect you with those information.
Great, thanks. And Sukrita, we actually have a related question that just came in, so I'll ask this to you at the same time, which is the benefits evaluation framework used? Is it available in our toolkits, and is it scalable for provinces that want to use it?
Absolutely. So the framework is very much available for everyone's consumption, and a number of studies across the country, not just specific to iEHR, various different digital health solutions have used this framework. And again, you can find this on our website, and there's some of the accompanying methodology with it, some of the tools accompanying is there, as well through the benefit evaluation reports available on our site. You'll see different uses of the framework. So for example, an EMR, for evaluating EMRs or for evaluating DIS. So for all of those different types of digital health solutions, you will see examples of how the framework has been applied.
Great. Thanks very much, Sukrita. So now I've got one for Bobby, and that one is how soon will patients be allowed access to the iEHRs?
So great question. We're hoping the answer is very soon, but actually there is work already underway, and there are patients in certain pockets of the country who can already access their information. We've got a lot of work happening in Nova Scotia on a provincial portal. As well, Alberta is working on providing their patients with access to the electronic health record, and we have a number of work underway with other jurisdictions to enable the same type of access to the iEHR. So definitely, it's already happening in some parts, and we're hoping very soon in many others.
Great, thanks very much, Bobby. So we got one question which I'll field, which is from a person that joined a little bit late and wanted to know if the content will be available, and the answer is yes. So if you've missed a portion of this, then absolutely we'll be putting this webinar up on our website, and you're welcome to, of course, view it and share it. So I have a next question here, which I'm going to direct to Sukrita, and it's about when we were looking at the benefits of an electronic record, including information availability, did we look at implementation of terminology services?
Great. Certainly, we do have a large presence within the organization in terms of developing standards and terminology, which has been widely applied among projects. So, yep.
Thanks, Sukrita. So another question that we've got here is around, and this one I'm going to direct back to Sukrita as well, and it's around the fact that there's many positive findings in those benefits, but there's also a number that are negative findings. And I was curious, this questioner was curious if we've seen any findings from those negative results. Is there something we can take from those?
Sure. So the negative findings, and as I mentioned in my last slide, which I'll just flip to. So really the negative findings involved us going back to those individual evaluations, and we did take a look at that data in certain evaluations, and it identified to us factors that could help improve those negative findings. And when they all largely came back to relating to the system and service quality. So it related to the users not being initially satisfied with the solution, or not being integrated into their workflow well, or them not feeling like they had the adequate training and support to use it. So definitely in terms of understanding the negative findings, it requires us to go back to those individual evaluations and do some in-depth analysis of what was driving the benefits and what factors hindered.
That's great. Thanks very much, Sukrita. Okay, and so I don't see any more questions trickling in, but a great discussion and some great questions for folks, and really wonderful to see the number of people that turned up to hear the presentation. As Sukrita mentioned, we do have a lot of resources related to these findings available on our website, and as she also mentioned, we really encourage folks to reach out to us if they've got evaluations underway or evaluation ideas. We're very much receptive to hearing from all of you about those and continuing the collaboration down the road. So thank you very much, Sukrita and Bobby, for those great presentations, and thank you to all of you for joining us today, and I wish you a great rest of the day.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.